Laboratory testing will have a whole lecture from Dr. Shah shortly, but I do want to go over some very basic points. Many difficulties with laboratory testing. As I mentioned, there are many different types of Borrelia, and we often have our blood tests based on one or two strains that may not apply to the others. The Borrelia will change over time, so what you developed as a blood test for a Borrelia may not apply to what's now happening weeks to months later in a patient. I'll give you an example of the genetic diversity. Outer surface protein C reflects just one gene locus, yet that one locus has 22 variants in Burrascano. And finally, the wild-type Borrelia specimens that we culture from our patients, they're quite different from the laboratory strains. Yet most of these commercial tests are based on one, maybe two laboratory strains. For example, in America, most of our tests are based on strain B31. This is the strain that was collected from ticks in Shelter Island. This strain came from a tick. It did not come from a human being. It was never tasted the blood of a human. Yet all of our tests, all the research, all the controversy is based on testing from a tick strain that's so different from what's in real people. Even if it was a human strain, it's one strain at one point in time, and it doesn't reflect how the Borrelia do change. Now, as a result, serologies are very insensitive. One published study that the range of sensitivity averages about 50%. I'll show you another slide on that. Many have heard of the C6 assay as being more accurate. It's as accurate as the standard ELISA. Now, here's some trickery. If you read the literature that supports the C6, they say it's 100% sensitive. It's 100% as sensitive as the ELISA, but it's not 100% sensitive in picking up Lyme disease. So if you read the articles carefully, you'll see that this claim of 100% is that it's 100% comparable to the ELISA, not 100% accurate for Lyme disease. The Western blot, very poor sensitivity unless it's done by a specialty lab. And in the presence of certain viruses, you can get false positive serologies. The other paradox, as I mentioned, the more ill patient is less likely to have a positive serology blood test because of immune suppression, immune complex formation, and so forth. And one big limitation of serology, of course, is it shows prior exposure, not if you're currently infected. This is from the article showing how insensitive the ELISA is. The author claims 49% on average, and he says it's like tossing a coin, 50-50.